estimates. So I think in insurance that we do have some element of certainty in it, because we, through experience and history, we sort of know the claims that are coming, and we know the cases, we know the risk issues. Obviously, we're uncertain. The uncertainty comes in, when are they going to occur and what damage or what impact they're going to have. And we have risks with opportunities. No show of hands required, but who's been to Vegas? If you like gambling, if you go to Vegas, you go to any casino, it doesn't matter. We take risks, gamble. Are there opportunities to that? There could be. There could be. And what you see in financial risk, especially, is that there's a probability that actual return on an investment will be lower than the expected return. It's the same thing again. You start off with your $100 and it's gone. It's nice that it was $200 or more, whatever on from there. But an uncertainty that it could have a positive effect on objectives, risks, and opportunities. I think of the pandemic, and it certainly threw us a curveball, all of us, in healthcare and in insurance. I think that there have been opportunities through the pandemic to develop our processes, develop our risk analysis, and do all these things to sort of move on and ensure patient safety. There we go. Risk management, clinical administrative systems, processes, and reports employed to identify, monitor, assess, prioritize, control, and prevent risks. It's as simple as it is. These are a lot of organizations take part in a thing called enterprise risk management, where they actually look at the complete system, the complete organization. And these are the 8 risk domains that they look at. To give you an idea, I'm not going to go into DRM too much, but you can see at the top there, they look at an operational domain: clinical, patient safety, strategic, financial, human capital, legal, regulatory, technology, and hazard. So they tend to base their whole plans, their whole risk management plans on these 8, under these 8 domains. It's a complicated process, but a lot of organizations do it to ensure there's a complete assessment of the organization. There we go. Okay. So what is a risk management program? What does it do? So by employing risk management, healthcare organizations proactively, systematically safeguard patient safety as the organization's assets, market share, accreditation, reimbursement levels, brand value, and community standing. It's from New England Journal of Medicine. So yeah, it is obviously patient safety is what we're looking at, but there are so many other things at risk within an organization, including reputation, brand value, finance, etc. Okay, so we're going to look at the process. We're just going to go over each and every one. So starting top left on the risk management process, you can see identify potential risks, moving down to analyzing the risk, then evaluating the risk, treating the risk, monitoring and reviewing the risk. So that's what we're going to briefly go over. So what do we do for proactivity? I think risk management for years was always about being reactive. An incident occurred and we looked at it, we evaluated it, and we tried to ensure that it didn't happen again. Things like root cause analysis are one of these areas we look at, we do. Yeah, it's not a bad thing. It really isn't a bad thing. However, we've tried to move into being more proactive. So that was a reactive response, but trying to move into a more proactive response. There's a process called failure effects and failure mode effects analysis. It's a prospective analysis of a situation across an organization to predict how critical each possible failure in the system is. So, for instance, this was used in the 1940s. It started in the 1940s in the military, and it's been used in aerospace, various other big companies to look at their risks, be proactive to prevent patient harm, to prevent harm from happening. Again, a lot of organizations actually use failure mode and effect analysis, but also it takes into account frequency, severity, and potential cause mechanisms of failure of each process, each part of the process. In order then it identifies which is each risk. These risks can be prioritized and addressed. Does anybody here think that they use failure mode and effects analysis in their daily lives? Because you do. In the simplest form, I came up with an idea. So that the drivers, cyclists, anybody else, the process in failure mode effects analysis, the process would be for you guys is you drive to work, you route to work. How do you get from A to B, from the house or whatever? Know that there's a traffic buildup ahead, and there's going to be roadworks for 6 months, which is the failure mode process and the failure mode. So when you do an analysis, an effects analysis, you look at the severity, the probability, and the outcome. So how severe is this problem? It's got a long tail back. You're going to be forever in this. However, consequences that you're going to be late for work. It's the greatest risk. Okay, you're not getting on well with your attending. You got rounds. You're going to start in 10 minutes. It's going to take you at least 20 minutes to get there. What do? Sit in the traffic and hope for the best? Do you take an alternative route? And ahead to take another route tomorrow, because you know the roadworks are going to be there for 6 months, 6 weeks, whatever. That is failure mode effects analysis. That's exactly what you do. Is you look at the sequence, you look at a process, you look at the risks, you look at the consequences, and you make a decision. So everybody does it. Simplest thing. Internal drivers and external drivers. Internal drivers. What have we got internally within a hospital, within a system that would lead to a risk occurring? What are the factors that create risks? And, we've come across lots of these things: staffing, workforce issues, bed shortages, medication issues, sentinel events. Sentinel events are never events. They're classed as never events. They're events that should never occur. Hospital-acquired conditions, readmissions, ED holds, one of my old favorites. External drivers will be, mostly around legal, regulatory, federal or state regulations and laws. Compliance and accreditation, we all know and love the Joint Commission. Observation, everybody, we observe, we look at the environment, we look at established and new procedures, and we look to see if there's any changes that are needed. We observe, we look around. Consultation, we talk to people. We talk to physicians and staff. We talk to everyone that's involved in the healthcare process. And we try and get some ideas about what is going on in their environment. It's very important. We ask them what they believe are risks. And as you may have seen on the floors when you're there, management do rounds, everybody does rounds. They round on patients, they round on staff. And also in consultation, we have numerous committees that deal with all issues in the hospital. There are risk management, there are quality improvement committees. There are things like this. Historical, traditional, what are the risks been? What do they look like in the past? How do they look like now? I think pressure ulcers is a great example of that. And back in the day when I had hair and I was, back in the day, pressure ulcers were being treated with egg whites and oxygen. That was it. That was the treatment. We've come a long way since then, but patients are still vulnerable to pressure ulcers. So what's the appropriate treatment? We've gone from years looking at nutrition and turning patients and pressure relieving systems. So these are historical, traditional risks we still need to look at, we still need to assess. Reports, we get reports from all over the country, and internal and committee reports, everything else. People build reports, they report on what they've seen. And we look at those and we try and identify risks from there. Feedback and surveys, again, we ask patients, we ask staff. You may have been involved, and I'm not sure, in the AHRQ Culture of Patient Survey, Patient Safety Survey, big one that's done every year. And again, important things to look at. Evidence-based practice, research studies, all important. And incidents, we look at incidents, basically. They're reported incidents that we know of. We look for themes. Again, root cause analysis becomes part of this. These incidents have been reported. There may or may not have been patient harm. But another important thing is we also review near misses. Which in a near miss, there's error, but no actual patient harm. Harm didn't reach the patient. I remember going back many years, and I was involved with a pharmacy project. Let's go back 30 years, perhaps, and they were interested in seeing how many pharmacy mistakes were being made with their whole process. And when I spoke to the pharmacist, I said, it was an interesting project. She said, yeah, there's a percentage of errors and everything's okay. And I remember back in the day, if you had a patient being discharged, you get the medication to come up to the floor, or a take-home medication, and you go through it. And it would be the wrong patient, or it would be the wrong medication, or there'd be something missing. So you used to just trot down to the pharmacy and you'd hand it back and they'd go, thanks. And they'd smile and the next lot. And well, that was common practice. Anyway, when we investigated these near misses, the actual incident rate went up by about 200%. It's happening everywhere. So, we now have processes in place to address this. We now have much, we'll talk about that. So, moving on. Okay.
Not working?
No. Try an arrow key. We go. Okay, common healthcare risk. List is not exhaustive. There are many more risks here. Legal, regulatory compliance, clinical, operational. As we've seen within the ERM 8 risk domains, they also come under there. Flawed systems and processes. Any surgeons here? Any surgeons? No surgeons? Okay. Nothing against you guys. Universal protocol in the OR. One of the reasons it was brought in was because they were flawed, basically flawed systems and flawed processes within patient care. Timeout process, all done deliberately because these risks had been analyzed. Flawed systems and processes. Privacy and security, HIPAA, main area of that divulgence of unintentional or even intentional divulgence of PHI, a big risk. Medication management. I think that, I said with the last example of pharmacy, we've come a long way, especially with CPOE. There are workarounds to CPOE, and I know that from personal experience. But I think that we've definitely moved streets ahead in medication management, and we'll talk a little bit more on that as well. Infection prevention and control, violence. It's become a far more violent society. We get calls in MICA probably every week at least from physicians out there in the community that are experiencing violence and aggression from their patients. Whether that's something to do with the pandemic, whether physicians' tolerance has become less, and they're quite happy to see these patients out the door. We certainly are getting a lot more calls about that. Cyber insecurity, ransomware. I was talking to the CEO of a large orthopedic group a couple of weeks ago, and he thinks that cybersecurity is his #1 risk priority. No doubt about that, #1. Ransom. Telehealth. How many of you practice telehealth? Couple. Risks with telehealth? Many risks. HK may add later on, but we've not seen a huge amount of claims, if any, with telehealth. But We think that down the pike somewhere will be claims regarding misdiagnosis or even delayed diagnosis. If you press on telehealth, how can you be sure you get an accurate assessment, which leads you to diagnosis, which leads you to your treatment plan? How do you know patients are being truthful? How do you know? So I hadn't met HK before, and we met him on Zoom. I realized how tall he was, as you'll see when he gets up here. But you know, there's things like that. How do you get an accurate assessment? Because everything else will depend on that history and assessment. Okay, falls. Patient falls, legion, cost billions of dollars every year. Pressure ulcers, as I mentioned. See if I can move on. Complexity, healthcare delivery has become more complex than it ever was. It still is complex. Still is complex. We're dealing with a different patient demographic. We've got sicker patients. We've got older patients. We've got patients with more chronic conditions. You know, complexity is there definitely, and that can cause risks. Competency. I'm sure you're all competent. But again, competency can cause risks. Equipment failure. Again, we rely on a lot of equipment these days. What equipment can cause risks? Patient alarms, big problem in risk management is ignoring alarms, or when alarms are muted or turned off. Civil rights. We've seen a couple of issues in MICA where patients have complained about their civil rights due to not being allowed to wear masks in physician practices. And that fits in with the ADA underneath ADA. They claim that they have a disability and they weren't treated fairly. I think we've got about 3 of those at the moment that we're dealing with. So yeah, civil rights. Americans with Disability Act, same thing. You know, those with disabilities and how you treat them equitably and fairly. Human factors, huge player, where none of us are fallible, none of us. I don't want to digress too much, but there was a documentary around about 2010 by Dennis Quaid, an actor who some of you may know. His twins were in the NICU and they were overdosed with heparin, both of them. So he set up a big thing called Chasing Zero, preventable medical harm. And it's all about all of us, you guys especially, in watching this video. And it's out there if you look on YouTube and whatever, you'll see it. It's about an hour long. It's just but you know, it looks at the human factors and what human factors are involved in preventable error. The whole thing is they want to chase zero. They want to get no patient safety issues. So no deaths from preventable errors. Will we ever achieve chasing zero? Will we ever achieve it? That's just slightly half empty, I'm afraid. You know, and the airline industries and everybody else has actually moved on with a lot of these things to make their processes safer, but we still have medical error and we still have human factors. Medical records and documentation, EMR, I'm sure you all know. How many copy and paste in the EMR? Just show hands, so but copying and pasting is dangerous. It certainly is dangerous. I've got a number of examples of that. I haven't got time to go in for them. Informed consent refusal. How do you ensure that the informed consent process and informed refusal process is solid? How do you ensure that patients have had the risks, benefits, and alternatives explained to them? Communication. Research, 60 to 80% of medical error is caused by miscommunication. So just have a think about your handoffs, your handovers. Just think about how you communicate within a team. Just think about how you communicate with patients. Very important. Decision-making, commission or omission. What happens when you commit an error, or what happens when you don't do something you're supposed to do, as in omission and other things. Diagnosis, as we discussed, is a risk, a huge risk. Even with differentials and everything else, it's a risk. And then treatment, again, in itself is a risk. How do you know that the treatment you're going to give is going to work? You know, what treatment do you decide on? Those sort of things. Just some of the healthcare delivery areas we've looked at across the years in medical professional liability insurance, and these are the top list Or the improper performance, which is exactly that. It's basically you're not performing how you're supposed to perform. Diagnostic error is the top one. And all these statistics pay costs with them. They're all well in the up to the billions. There are a lot of money involved. Failure to recognize a complication of treatment, failure to supervise, monitor a case, medications for medication error, system failures, as we discussed in communication. So what do we do when we analyze risk? We look at the risk inventory. We decide on what the risks are, and we put them all in a list, and we look at them like that. And then we rank them. We look to see which ones are needed to be prioritized and which ones could probably just go down. In patient care, it's difficult because there really aren't any risks that aren't important. You know, you may have other organizations that can rank the risks and just ignore the ones at the bottom, but you know, we've got to look at everything. Likelihood is looked at of the risk, the impact consequence, and the velocity. How quick is that risk going to get to the patient? That's another important factor. And you often see these as the risk matrix, which looks on the left, you say the likelihood of the error causing harm and the consequence. As you can see, you know, almost certain likelihood and a catastrophic consequence is goes to 25. So basically all the risks are scored. How do we treat it? There's about 5 ways we can look at treating risk. Do we accept it? Do we accept the risk and we move on? We do nothing about it. We avoid the risk completely. We tolerate the risk. There's the risk tolerance and risk appetite sort of go together hand in hand. We don't have a tolerance and an appetite in healthcare. We can't afford to have that. So again, other organizations may look at the risks and go, okay, that's fine, we're going to look at that. Risk transfer. You transfer your risk to insurance companies. You also transfer risk when you do things like you get a patient sign an AMA form. You're transferring the risk to them. You're informing them of the consequences of their actions, so you transfer the risk to them. You mitigate the risk. Something we probably do most of anything else is we mitigate this. We try and reduce harm as far as we possibly can. And there are positive, negative outcomes, costs and benefits in all of this. And this is, everything is weighed up when we look at risk. Okay, so we monitor risk. We've made a risk management plan. Is it effective? How does it work? Do we need to look at any of the risks again? Yes, we do. We look at them all. We reassess, we audit, we do trend analysis, good performance indicators, and we look at research. We look again at internal and external factors. How are they affecting what we do and how we do it? And then we identify required changes and new risks. And then again, we go back to prioritizing, and then we go back to the full circle again of the risk management process. It's a continuous process over and over. So on professionalism, where do you all fit into this? Hopefully, you know, throughout your careers, you've known through med school and on your residencies, you know, you're aware of a lot of these issues. But you know, I think the catalyst for change in patient safety came after the Institute of Medicine's report, which you're probably aware of. It's to err is human, back in 1999-2000. They stated at the time that between 44,000 and 98,000 patients die each year through medical error, preventable medical error. There have been studies and sort of meta-analysis on from there, not many, but a couple of studies that push that figure up to 250,000 a year. There is criticism of the methodology of these studies. You know, I think that we have to take some of them as a pinch of salt, but over the years, we've had phrases such as more Americans are killed in US hospitals every 6 months than died in the entire Vietnam War. The equivalent of 3 fully loaded jumbo jets crash every other day is the amount of patients. You know, that could be a bit of if you know what I mean. But, you know, I think the bottom line is in trying to chase zero and trying to look at preventable harm, any number of patients dying is really where we should be aiming for, is to reduce those numbers regardless of the match. So no one wants to cause patients harm. And patient safety has become a moral imperative for all of us. We really have to do these things. So professional obligations. First, do no harm. There you go. That's the end of the notes. First, do no harm. That's it. That's what it's all about. That's what you signed up to. That's what you swore to do. And, you know, you have to do it. But we look at, you know, behavior. There's, you know, physicians' behavior, integrity, honesty, respect, accountability for actions, effective communication. Again, we've been through that. Competency, keep your knowledge up to date. Reflective evidence-based practice. You have a duty of care, and within that, you're expected to maintain professional standards and maintain this. All these things fit in nicely into risk. We're going into the next one's risk recognition, risk prevention, and risk response and reaction. You know, reflect on your practice. Look around you. Ask for advice. There are plenty of people out there who will give you advice on any areas you need to look at for reducing risk. Talk to colleagues. Get a team approach going. You know, look at your teams, look around you, look at the environment that's going on. You know, risk prevention is everybody's responsibility. I think that's important for me to get over. It's your responsibility, it's mine, it's everybody's responsibility. Again, reflect on your practice, seek advice. You know, at MICA, we get daily calls from physicians and practice administrators as well. They ask for advice, they ask how to reduce risk, what they can do to, you know, to patient safety, keeping themselves out of trouble, reducing their liability, all these things. Okay, risk response and reaction. It's important, and HK has the contact details on his slides, but it's so important to be able to react to risk and respond to risk and notify the right people that you've seen risk or that you've been involved. If you do make a medical error, do not hide it. Do not hide it. Please report it. Please tell people they're there to support you. So some strategies we have, as I say, we have a risk management plan where everything is set out. Organizations rely on that. Assessment and reassessment, policies, procedures, protocols, and processes. Again, so important. We have a lot of cases. We have a lot of questions from physicians. I always suggest that they need policies. They need guidelines for them and themselves and their staff. And policies are going to be asked for in a court case. They really are going to be asked for. Communicate and educate. That's why you go through much training and education. It's all about addressing risk. It's all about managing risk. And communication is so important part of that within the organization and within your teams, as I say. And organizational learning and a safety culture. Very quickly, nearly there. Commitment, a safety culture, organizational safety culture, these are the sort of main tenets of it. So the commitment to safety permeates through the organization. Everybody looks at safety. A consistent minimization of adverse events, event reporting system, transparency, and disclosure. Data and event analysis result in improvement, system change, process design, continuous improvement, staff and patient education and engagement. Teamwork and interdisciplinary collaboration, just culture, blame-free environment without fear of reprisal or retaliation. So if you make an error, most of the time, if not all, the just culture process will work. And so this is what it looks like. So we're looking at human error on the left-hand side there. I had a call yesterday from a surgeon who assessed the patient twice in his office and took him to the OR for a planned procedure. Saw the patient just before he went into the OR, and the anaesthetist was there, anesthesiologist, British after all these years. The anesthesiologist was there with him. Took the patient to the OR and they couldn't intubate him. He had a very narrow trachea, and it was impossible to intubate him. So they woke the patient up, went and spoke to the family, and the family said, oh, he's had a tracheostomy in the past. And the surgeon said, I knew nothing about that. And the anesthesiologist missed it as well. You know, what are the issues there? Obviously, you know, perhaps his assessment, perhaps the surgeon's assessment wasn't good enough. And often you ask patients, as you know, do you have any respiratory problems? And they'll say no. Well, perhaps this guy didn't have any respiratory problems at the time, but obviously he did in the past at some stage. So, you know, you're looking at how do we manage changes in this, in behavioral issues, in human error. And we look at choices, processes, procedures, training, design, and environment. You know, how do we adapt those to look, is there a process? Does this surgeon's processes need to change? His H&P needs to be a lot firmer. Does he ask the wrong questions? These sort of things. But, you know, it's human error. I think moving on from the at-risk behavior, this becomes more serious. As you said at the bottom, console for human errors. This is what should be happening. At-risk behavior, this is basically, you know, we all take risks for different reasons. We know that. You know, is this behavior that needs to change? And this is something that needs to change. Managing through removing incentives for at-risk behaviors. Smoking is a great example of this, not in risk management, but if you know what I mean, you can see it in there. Basically, the bottom line is you need to coach for this. And then far right reckless behavior. This is where people have just completely broken the rules and know they're breaking the rules. And basically conscious disregard is something we're looking at, and justifiable risk. And they will be punished, and often that will involve things like the board revoking your license, or even suspending it. But these are important bits. I'm going to finish on there because I've run over slightly, and I do apologize to HK. Answer questions at the end. That's all right. Thank you.
Thanks, Jeremy, and thanks everyone for being here today. So I'm HK Collins, and I am a risk manager like Dr. Hodder, and also an underwriter. So my specific area of specialty is in medical malpractice and professional liability insurance. And just sort of jumping off, this isn't part of what I was planning to talk about, but it's a good sort of nexus between what Jeremy was talking about and what we're about to talk about here. I want to touch on professionalism, which was sort of at the end of Jeremy's talk. And if anybody were to ask me before a claim arises, what's the best way to avoid a claim, I would say it's probably to increase your professionalism. What do I mean by that? Treating patients with respect, treating your colleagues with respect. I know that you all intend to do that, but there will be times when you're frustrated and you sort of lose your way a little bit. That happens to everybody. But it's important as professionals to maintain and to practice these professional standards. It is probably the single best way to avoid a malpractice claim being made against you. So with that, let me sort of jump into what I was planning to talk about, or what I am planning to talk about, and that's professional liability insurance. And I want to leave time for questions at the end. So with that idea, I'll mention that this is a discussion that could probably go on for, well, that I could go on for like 6 hours or all day even, and I'm going to do it in about 6 minutes. So what is it? Well, you sort of have a good sense probably already about professional liability insurance and what it is. This, by the way, is a brief outline of what we're going to talk about in these few minutes. So what is it? What do you need to know about it? There are some unusual features of medical malpractice insurance that are different than the insurance that you're most familiar with in your personal lives. And then we'll talk about some of the details that are very specific to the insurance that you're covered under, and some very specific things that you need to know about it. All right, so what is it? Well, it's protection against allegations of medical malpractice. So an insurer has really two responsibilities. It's to indemnify for acts of, well, to indemnify for the legal obligations that their insureds are responsible for, but it's also to defend the allegations made against them. And that's a very, we get into some very specific defense obligations with medical malpractice insurance. And I'm going to talk about that a little bit later when we talk about consent. But in general, professional liability insurance is what will protect you from the financial consequences of claims when they occur. And it's worth mentioning here that almost every physician will be involved in a claim in their, or even more than that, will be involved in a lawsuit in their professional life that relates to the care that they've provided. And you know, when in the best of circumstances, when everything goes right, there will still be bad outcomes, and it's unavoidable. And those things tend to lead to claims and to lawsuits. And everybody hates writing the check for their premiums every quarter, every year, but you'll be happy that you did when these things happen, because they will happen. So almost every physician is involved in a medical malpractice claim during their career, and most physicians are involved in multiple claims throughout their career. You're working in an inherently risky environment where the consequences of the work that you're doing, even under the best of circumstances, can be catastrophic. Professional liability insurance is not required in many states, but it is required by most hospitals and other contracts that you'll enter in your professional life. Arizona does not require physicians to carry malpractice coverage. Many states do. And finally, malpractice insurance, it's worth mentioning here what it doesn't cover, and it does not cover things that do not arise from professional liability incidents. That seems obvious at first, but there are some sort of like crossover events that are not totally clear. A couple examples are OR fires. I spent a lot of my career in Los Angeles, and in LA, we deal with something that we don't deal with a lot in Arizona, and that's earthquakes. So when an earthquake happens, it's kind of tough to get a patient out of the OR quickly. Something falls on the patient. Is that a GL claim? GL, by the way, is general liability. Is that a GL claim, or is it a PL claim? EPL is employment practices liability. There's a lot of sort of gray areas in the margins about where, about which policies might apply. Another good example is a patient who signs in to be seen by their physician, and while they're waiting, they go to the bathroom and they fall in the bathroom. And sometimes, sometimes that's not a big injury, and sometimes it's a really big injury. So is that a GL claim, a general liability claim, or professional liability claim? Any thoughts? GL claim? PL claim? So most people thought GL claim. I will say that in different venues, I think that that there are different views of that. Most venues, I think, would actually consider that a professional liability claim. There's quite a body of law that has developed around this idea of GL versus PL in different venues where tort reform is active. That's not the case in Arizona. It is the case in California and in a lot of states, because there's a lot of dispute about whether a particular incident qualifies for the tort reform protections that medical malpractice claims have. So there's actually a lot of case law that's developed around the idea of, is a particular event a professional liability or a general liability event? Most of those venues would say that a patient who checks in with or who signs in at their doctor's office but then has a fall is actually a medical malpractice event and not a general liability event. But it's not always clear. So this slide, I don't have many slides, by the way, and I know I'm going fast. This slide, by the way, has the only thing that's highlighted, and so you know it's important. But I want to talk about a couple of things. These are sort of unusual features about medical malpractice policies, and most of these things won't be too important to you for the next 2 or 3 years, but then they'll be really important to you when you're practicing on your own. So the liability insurance that you're most familiar with in your personal lives is occurrence coverage liability insurance. What that means is that the insurance that's the policy that's in force at the time of the triggering event, the car accident, the dog bite, the whatever, that's the policy that applies. So that's occurrence-based coverage. Most malpractice policies, and I think it's probably true of just about every policy that's sold in this state, is a claims-made policy. It's different, and it's an important difference, and it's very important for a reason that I'll get to in just a minute. But claims-made coverage is coverage that applies at the time the claim is made, not at the time that the occurrence happens, the triggering event. So claims-made coverage is what most malpractice policies have. And so here's the big takeaway. If you remember one thing from what I talk about today, I want you to remember this, that because claims-made policies cover only claims made during the policy, it's critically important to report occurrences when they occur in order to trigger coverage. So what's an occurrence? An occurrence is an unexpected outcome with poor consequences. So I'm treating a patient, and the patient, I'm a psychiatrist, I'm treating a patient for depression and they die, and from suicide. And is that, I don't think I did anything wrong. Nobody has made a claim against me. I don't really have a reason to contact my insurance company about that. But you can trigger coverage under a claims-made policy by reporting the occurrence. And then if a claim is later made, you've triggered coverage under the policy. This is a good time for me to mention that every policy is a little bit different, and we'll deal with this a little bit differently. Most policies have this occurrence trigger in it. And that's the sort of the key thing I want everybody to remember. Retroactive date, for everybody in here, it's July 1st of this year. I'm not going to talk too much about that other than to say that a retroactive date defines the period of occurrences that apply to your policy, and the effective date applies to the claims that are covered under the policy. It's a little bit wonky, and so I'm going to skip it because we're running out of time. Most professional liability policies have a consent to settle provision in them, which means that unlike your auto policy or your homeowner's policy or other policies that you're more familiar with in your personal life, the insurance company cannot settle a claim without the consent of the insured. With the Creighton policy, the policy that you're all covered under, consent resides with a named insured, which means with Creighton. In policies that you purchase on your own, you'll be the named insured, and you will hold that consent right. There are other related coverages in most medical malpractice policies, including the one that you're covered under here, that it covers things like personal injury, subpoena response, medical board actions, and things like that. Those are not what we would consider claims under the traditional definition, because they don't arise from, they're not They don't create a legal obligation for damages based on professional liability, but they still qualify for coverage. So covered under the Creighton program, just some specifics, claims alleging treatment errors. Treatment is defined sort of broadly here. It doesn't just mean medical care, but it means mostly medical care. And I won't go into all the sort of wonky details of that. Things within the course and scope of duties within the program, and it also that also includes approved moonlighting activities. So if you are moonlighting, you're covered under the Creighton policy as long as the moonlighting is an approved moonlighting activity. Here are things that are not covered, which is basically just the opposite of what I just said. So I'm going to, I talked a little bit about like GL and auto and things that sort of fall into the margins of coverage. Unapproved moonlighting activities also not covered. And you sort of probably have a good sense already of what's not covered. So we talked about why it's important to report occurrences. This is where you would report them. So this is so Katie Booten is Creighton's risk manager. Her information is here, but if you don't write it down or you don't remember or whatever, just Google Creighton risk management, and that's the first result that will come up. And we're also happy anytime to answer any questions or anything that comes up related to the policies of insurance that you're covered by. This slide has names of the people who are dedicated to the Creighton account. Robin Reithinger, who's here with me today, and Ted Munkowitz, and then me, H.K. Collins. Okay, happy to answer any questions, take any questions.
I have a question. Hey, so when residents graduate, do we need to start paying for tail end coverage for our residency?
It's a good question. And just to reiterate, in case everybody, to verify that everybody heard, do you need to purchase tail coverage after graduation? So tail coverage, the short answer is no. Tail coverage is coverage that extends the reporting period for occurrences that happen while you're covered under the primary policy. So I mentioned at the beginning that this is a claims-made policy, meaning that the policy that's in effect at the time the claim is made is the policy that applies to the claim. There's a feature called extended reporting period endorsement. Everybody calls it tail coverage, that extends the period that you can report and have claims covered under the primary policy that, for claims that occurred during that period. The Creighton policy has purchased indefinite extended reporting period endorsement. So there's indefinite tail coverage on the Creighton policy.
So if in 2 years someone said, I'm gonna make a claim now, we're still covered, even though we haven't been in the program for 2 years.
So we always are careful about saying, am I covered? But the policy would still apply.
Thank you.
You're welcome. Can I answer any other questions?
You can see if any have come in.
And Dr. Hodder, I know is also happy to address any questions. Thanks. I know I was really fast. I know I was sort of zooming through it, but there's my information. Happy to answer any other questions at any time. Thank you.
Thank you to HK and Jeremy, and you will also have access to these slides and the recording. We will get that out to all of you. Okay. Oh, and the QR code is back on the table here at Valleywise. So make sure you follow it. Thank you.
Food's a story.